In this video, we'll discuss the management of multi-drug resistant Pseudomonas and Acinetobacter. And as we discussed before in the previous video, the Pseudomonas can be classified into carbapenem-resistant Pseudomonas or difficult-to-treat Pseudomonas. And in general, if the Pseudomonas is carbapenem-resistant and sensitive to the traditional antibiotics, we can use either cefepime, piperacillin, tazobactam, astrinam, ceftazidime, or fluoroquinolones. But if it is difficult to treat and it is sensitive to the novel antibiotics, we can use ceftazidime, tazobactam, ceftazidime, avibactam, cefderichol, and imipramine. But if it is resistant to the novel antibiotics, we can use second-line therapy like aminoglycoside and colistin. For Acinetobacter that are resistant to the carbapenem or carbapenem-resistant Acinetobacter, we can use either colistin-based combination using colistin plus sulbactam or tigecycline-based combination using tigecycline plus sulbactam. And the dose of the sulbactam either used ampicillin sulbactam 9 gram every 8 hours or 27 gram over 24 hours continuous infusion, or using cefeprazone sulbactam 3 gram every 6 hours or infused over 1 hour. And there is a recent update in the modification of the dose of the sulbactam according to the renal function published in the UpToDate. And here, if the creatinine clearance more than 30, we use 9 gram every 8 hours from 15 to 29, 6 grams every 8 hours. Less than 15, we use 6 gram every 12 hours. And if the patient have in continuous renal replacement therapy, using the full dose 9 gram every 8 hours. And there is some notes about the use of tigecycline in general in multi-drug resistant gram-negative bacteria. The rule number one is that tigecycline could be used as a monotherapy in biliary or intra-abdominal infection. Tigecycline could be used as a combined therapy in pneumonia with double standard dose. The rule number three, the tigecycline should not be used for bloodstream infection and urinary tract infection if there is an alternative therapy. But if the pathogen is sensitive only to tigecycline, use it irrespective to the site of the infection. And this is the resources that discuss the gram-negative management of the multi-drug resistant gram-negative bacteria. We have Infectious Disease Society of America. We have clinical infection and microbiology from the European Society. We have also sources from the China as an Asian guideline. And to summarize the management of the multi-drug resistant gram-negative bacteria, we will start by Enterobacterus, third generation cephalosporin resistance Enterobacterus. If the patient have a urinary tract infection and this infection is non-complicated, we can use piperacillin, tazobactam, quinolones, or oral fosfomycin. If the patient has a complicated urinary tract infection, you can use aminoglycoside or carbapenem. If we have a bloodstream infection or infection outside the urinary tract, and the patient we have without septic shock, we can use ertapenem, and patient with septic shock, we can use meropenem and or imipenem. For carbapenem resistance Enterobacterus, if the infection is non-severe, we can use aminoglycoside or carbapenem, especially if the meropenem MIC less than 8. But if severe infection and you have new beta-lactam, beta-lactamase inhibitors, and these antibiotics are sensitive to the pathogens, we use it according to the genetic producing genetic pattern, either KPC or OXA48 or metallobeta-lactamases. And if you don't have new beta-lactam, beta-lactamase inhibitor, we can use any combination from the old antibiotics plus or minus carbapenem or meropenem. And for carbapenem-resistant Pseudomonas aeruginosa, if the new antibiotics are available, like ceftazidime, tazobactam, or cefazime, avibactam, or cefderichol, we can use it. But if the new antibiotics are not available and the old antibiotics are sensitive, we can use either piperacillin, tazobactam, polymyxin, or gentamicin. And lastly, for the carbapenem-resistant Acinetobacter pneumoniae, we can use any combination between of polymyxin, aminoglycoside, tigecycline, IV fosfomycin. We can still use the carbapenem if the meropenem MIC is less than 8. Thank you.